You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is March 12, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, HIV Update. Our presenter is Dr. Marianne Frieri. She's the Chief of Allergy and Immunology at NASA University Medical Center and Professor of Medicine and Pathology at State University of New York in Stony Brook. All right, well, welcome back to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. We're very fortunate today to be joined by Dr. Marianne Frieri. Let's pull up Dr. Frieri's slides. Dr. Frieri is the Chief of Allergy and Immunology in the Department of Medicine at NASA University Medical Center. She's also a professor of medicine and pathology at State University of New York in Stony Brook. I've known Dr. Frieri for a long time. She's an excellent teacher and a very nice person. And Dr. Frieri has agreed to speak with us today about HIV, or human immunodeficiency virus, something we don't actually see very much of here in the Kansas City area, but unfortunately in the New York area, my understanding is that it's a bit more common. And that's unfortunate, but that's what makes you the expert. At any rate, welcome to Conferences Online Allergy, Dr. Frieri.
Thank you so much, Dr. Portnoy, for the beautiful introduction. So we'll get started here, and I have all the references on the slide. So next slide, please. Okay, this is a great article that I'm sure all your fellows have in JACI 2010. Why it's here, it talks about defects in immune function. So notice we have adaptive and innate immunity. However, the important thing is we're going to talk about the top left. I don't have a pointer, but you can see HIV is, does it work when I point right here? Yes. HIV is at the top, and we're going to discuss that topic, not stress or extremes of age or other areas, but I highly recommend you read this article because it goes into HIV. Next slide. HIV is worldwide. 33 million in the individuals, and we do have an HIV clinic at our hospital. We see quite a bit. In fact, I had one today. This is adapted from the United Nations program, and it's 2008, but it's a good thing to show because it's also in Dr. Chinnen and Scher's article 2010. So you'll see it when you read the JACI article. Next slide. This is a bit older, but what I show is you can see what the HIV is with the different proteins, the P32 ingrase, the GP120, which we actually studied with one of my eCrypt fellows in the lab at Downstate, and we looked at some basic science, GP41. These are all the core proteins, and this is what happens when you have the budding that occurs with the HIV protein. And many of you know this, but I just thought I would show you that that picture of the core, the proteins, and what the budding looks like coming out of the cell. Next slide. Again, a very busy slide. It's an old slide, but the reason I put it here is because it shows the different proteins, the GAG, the POL, and all these links here, the nucleocapsid proteins. They're all listed here and what they do, and it kind of helps you understand these genes. I know Dr. Portnoy is very big on genetics, so you can read what different genes do, what their KD is, and what their function is, and that's why I put this in here just so you can see it in color. Next slide.
It doesn't look like it's that complicated a virus. I mean, I'm impressed that the number of proteins produced by this virus is actually fairly limited.
Well, yes, but you're right, Jay, in a sense. And that's true, but you know, there's so many new things happening now with a lot of these genes. So, but you're right. You would think that it would be more complex, but these are the different types of regulatory proteins that are targeted by the drugs that are listed toward the end of the study when we talk about the new treatments that are used for this condition.
Is this fairly typical for a virus, or is this simpler or more complicated than a normal virus?
Well, this is very simple. If you notice the reference, it's CUBI Immunology. Now, the reason I put it here, I downloaded it from a textbook I used for medical students, and it's 2007, so it's a little more complex. I put this here because it's kind of easy to see the different genes, the protein product, and the functions. But this looks simple. It's a little more complex, which you can see in the Jackie article, but you're right. Okay, next slide. Again, this is out of the same CUBI. This is the book that we use. But this is the, again, you can see the activation, the infected target cell, and you have a provirus, and then you have the CD4, which is the helper cell. And then on this side, but I'm not going to read them, you can see the GP120 binds to CD4 on the target cell. Then there's a fusionogenic domain, and then you have all these little steps going, containing the genome and enzyme that enters the cell. So these are steps. These are out of CUBI, and it kind of defines what we see in not only an infected cell, but an activation of a provirus. And then when you get way down at the bottom, you can see the buds that I showed you on the other slide that buds out, and the release particles that form. So again, a simple slide. It's a slide that I use for students, but it's kind of, it shows it in a diagrammatic way than just talking about it. Next slide.
Does the virus actually insert itself into a specific place on the DNA of the host cell, or is it just random insertion?
No, it does insert, and it's not necessarily random. As you can see, there's a reverse transcriptase, there's forming of this, and then it's translocated to the nucleus and integrated into the host chromosomal DNA by the integrase system.
But does it integrate into just a random place in the host DNA, or is there a specific place that it prefers to locate itself?
I think it's the specific place, but I can't tell you 100% right now for that.
Huh, interesting.
Okay, so this is out of CUBI. Again, made it very attractive to show you the HIV provirus buds with newly formed viral particles. This is the infected T cell. You can see the budding. This is an electron microscopy. And this is a slide showing the dendritic T cell interaction with passage of the HIV. What are the green dots? You see those little green dots here. So it's passage here, dendritic T cell interaction. And you know that the doctor that got the Nobel Prize for dendritic cells, Jay, was great, and unfortunately he didn't make it to receive his prize last year.
Oh, yeah, I heard about that.
Yeah, he was a great guy. He was at Rockefeller. He did a lot of work on dendritic cells, but he was great. Okay, next
he
slide.
actually died between when they nominated him and when he was announced.
Yes, absolutely.
So, which is strange, because they don't award Nobel Prizes posthumously.
Right.
But he was alive when they awarded it. He just died before he received it. So
that's exactly right. That's right. Yeah, I read his whole biographic sketch online. He was a great man, and we heard him speak at the Academy, if you remember, on dendritic cells at the Academy.
Yeah, yeah.
Well, next slide. Now, another tough one. The reason I show this, you all know this is classification of indicator diseases. Again, I put it in because it's clinical diagnosis. You know, I actually read the flow cytometry at the hospital, so I read off for pathology, even though I'm not a pathologist. So again, these are the counts, greater than 500, 200 to 4, and under 200, and they classify them. Remember, it's an old slide, but they classify them in these categories, whether they're asymptomatic with no symptoms, or B, whether they have all these other horrible conditions that you see, angiomatosis, candidiasis, listeriosis, and then the C category is over here, which are other disease states that we see, like crypto, histo, Kaposi's, lymphoma. So it's a tough slide, but I put it in because it's a nice table to kind of look at the clinical diagnosis. And unfortunately, we see this. We had a patient with lymphoma that was also HIV positive, but did not have a lot of the other infectious complications. Next slide. This is an old slide, and then I'm going to get to new slides. This is out from Dr. Fauci, who I'm going to end with. Dr. Fauci gave the best talk I heard on vaccine in D.C. last year, where I attended the AFMR, and that's toward the end. But this is an older slide from the American College of Physicians from Fauci on immunopathogenic mechanisms. So we have the CD4 T cell, which I'm sure you all measure. You all measure absolute count. There initially is a primary infection, then it falls down, and there's like a latency period. Over weeks, you see this, and then finally, time after infection, things change after the latency. Then there's symptoms, which can occur years later. Then the opportunistic diseases set in, and then unfortunately, death occurs. And we don't see this that much anymore because of the medications we have. In fact, in Africa, there's still a lot of problems because not everyone gets the medication. So this is a plasma HIV load that's done in our virology lab. So you measure the count, you measure the plasma HIV load, and of course you follow over time these patients. Next slide. It's an old slide, but it's a good one. Again, you can have various things. You can have endoscopic histology for depletion in the GI tract. This is HIV negative. Here's HIV positive. Here you see lymphoid tissue, and you see the difference in the negative and positive. And then, of course, if you compare the GI tract with peripheral blood and lymph nodes, you see the differences in those that are negative in green and those are positive in red. I just put this in to show you comparison of T cells from GI, blood, and lymph node. Again, a simplistic slide to show you differences in a nice color fashion. Next slide. Again, here's a slide that goes into the different forms where you have inhibitor of integrase here, you have the inhibition of reverse transcriptase here, inhibiting fusion, here's the virus here, and then these are different forms of where you can see the virus affects the cell, and again the budding, which I showed you before, and then finally maturation. So these are all the different things that occur when there's HIV provirus activation, transcription, and you're the geneticist, Jace, but again, this is an old slide, but again it shows diagrammatically what happens when you inhibit integrase, reverse transcriptase, fusion, and protease. Next slide, and then the drugs we'll talk about do that, which are amazing because in the 1980s when I came here, I was running the HIV clinic with my one fellow from Israel. We presented papers, and it was just us, and then the HIV started after that. So we've come a long way now to take care of these people. This was one of my ECRIP fellows, Dr. It's a long name, Meggie Disha, I can't pronounce her name, and one of our ID docs. We presented this, a 30-year-old male referred to our hospital for shortness of breath, history had hepatitis, CMV, syphilis. And again, what was interesting, he looked pretty well, but he had some respiratory distress. He had hyperpigmented spots. His lymph nodes were palpable, and his heart exam was regular, but we knew there was something going on with his past history. Next slide. We published this in Allergy Asthma Proceedings, which many of you probably have seen. Next slide. Chest x-ray was remarkable. It increased density in the mid aspect of his right lobe. On CAT scan, he had scattered right lobe infiltrates with nodules, axillary adenopathy, and then he had large areas of matted lymphadenopathy in the neck. AFB was negative, but culture was positive. Next slide. I'm sorry for this. It's in the paper. We did a profile in viral serology. He had abnormalities in his lymphocytes, in his helpers, and the HIV viral load was abnormal. Here it is down here. It was very high. This is the HIV load done by our virology lab. And of course, he had the other panels for EBV, which we do. So this was some of the blood work that was done. Next slide. Nicer in the paper than the slide shows. But now what was interesting, he had a diffuse lymphocytic non-Hodgkin's lymphoma, which many times, unfortunately, you see this in HIV. You can see here's his x-ray, and he had what's called the tumor. The follicles are absent, and he had these absence of a follicle, but he had tumor lymphocytes which are monomorphic. You can see this lymph node was infiltrated by tumor cells, and it was a B-cell origin tumor. Next slide. Well, what are the abnormalities? Obviously, there's a stage that's early. There's lymph node structure. There's changes in the cells, the dendritic cells, and then there's damage in the tissue. Then also you have the helper cells, the CD4, which early on there's no in vitro response to antigen. We used to do this in my lab when I ran the lab, which I don't do anymore. We used to do specific antigen to tetanus and EBV. And then later there's antibody production enhanced, nonspecific IgG and A, but reduced IgM. Later on there's no proliferation of B cells. There's cytokine production. Again, it's an old slide, so we don't go into all the latest cytokines. There's increased levels of some. There's delayed hypersensitivity, and then there's normal reactivity early to cytotoxic, but later they have reduced elimination of the CDL activity to impaired antibody to generate cells from T cells. Next slide. Probably put too many slides. This is great. This is recent. You got to read this. This is Moore and Fauci, Nature Review Immunology. You like that slide, Jay?
It's a great slide.
Okay, this is the paper all your fellows have to read. Now, Dr. Fauci had Dr. Moy write this paper. This is B-cell exhaustion induced by persistence of HIV and ongoing viral replication. So I'm not going to read the whole thing, but naive B cells respond to antigen migrating to T cells, and they become activated. So you have a naive cell, there's proliferation, and then there's either resolved infection, and then there's the restored cells, or there's persistent infection with enhanced B cell, activated B cells, or short-lived plasmablasts. So this is very interesting because there's a decreased diversity, there's inhibitory receptors that are expressed, there's poor proliferative response and enriched virus-specific response. So great paper. I put it in. I actually put the figure down here to explain it from the paper, but this is really a great paper, and I have more of these slides in this talk. I think it's the next one. Yeah, this is more Fauci's paper. So, persistent HIV is associated with increased activation, B-cell compartment, and hypergam, polyclonal B-cell activation, and terminal differentiation with a lot of autoantibodies. And that's why you get these B-cell, you get increased B-cell malignancies, lymphomas, and other disorders. There's also concern that the rates of cancer, including those of B-cell origin, remain high in the population for better understanding of pathways of surveillance. Again, this is 2008, and there's a lot more since you can PubMed, but many features of B-cell dysregulation suggest a role for aberrant immune activation through this factor with a lot of malignancies, as we see, and again, it's the same reference. So I basically went over the earlier figure with this, slide. Next slide. And here it is again. This is the same article by Moore and Fauci. Again, here's all the cytokine. Now, Jay, you'll have fun with this because you can quiz all your fellows. You'll like this one. In the bone marrow, you have the immature B cell with all these cluster-defined molecules, and there's the long-lived with all these. Then finally, that's in the bone marrow. In the periphery, you have immature transitional B cells with increased association of the HIV T cell lymphopenia. Okay, then that moves to the naive mature B cell, and you can see now we start getting a lot more of activation. We get short-lived plasmablasts, a lot of tissue memory B cells, increased viremia right here, and then finally resting memory cells. So the description of this figure is below. I won't read it, but it's all here. It basically says what I said, that it's expression of CD9 in the absence of CD27. We only measure the normal panel. We don't measure 27 or 21. So A is chronic viremia, okay? And then that's associated with expansion of these cells. And then what's interesting that the B cells downregulate their expression of CD21 and CD27, the short-lived cells, and B is the infection with loss of resting memory cells. So it's a nice paper to read. There's a lot of immunology there, and it's very nice study. Next slide. Again, here it is. I like this. This is another one. Now, Jay, you're going to like this one because this talks about not only the GP120, which is what we did in pulmonary lung cells with my last ECRIT fellow. We actually took GP120, put it in pulmonary cells, and we did apoptosis. And what happens is you have the GP120 here, which binds to the B cell. This is the HIV virion. And then the macrophages are also involved here. So there's direct effects of virions on B cells, binding of complements through the CD21, okay, that's important, binding of complements through CD21, enhancing dissemination, and apoptosis, okay? And then these are all the indirect effects through different factors. Here's all the cytokines. There's LPS, you know what that is, lipopolysaccharide, BAFF, which we, in rheumatoid arthritis, we deal with BAFF, TNF, IFN-alpha, IL-6, IL-10, IL-7. These are all the indirect effects that affect the B cell that then go on to activate more B cells, and even gamma interferon is involved here. And then there's increased apoptosis and decreased survival. Okay, so what happens is binding to the GP21 induces B cells to secrete cytokines such as the TNF and others, and then the secreted NEF from the sites can diffuse into B cells and suppress the switch. Again, same paper, great article, nice pictures, a lot of immunology on the direct and indirect effects of HIV on B cells. Next slide. So it's not just a T cell disorder, it's a B cell. And this is a summary. Again, here it is. HIV begins with binding to the molecule and also affects the chemokines, CCR5. Infected cells migrate where they replicate, and then during the HIV, the gut-associated tissue is severely depleted. So there's GI disease, prominent loss of memory. So there's apoptosis, cytopathology, cytopathic effects, apoptosis with more activation, and cytotoxicity. Now, these are some more references. If you want to read them, they're earlier than the Moy article. In addition, you all know what apoptosis is. There's also autophagy, which the organelles are direct toward the lysosomes. And then there's the acute phase, 1 to 6 weeks after infection, such as fever, fatigue, headaches. And again, more references if you want to read them. But this is really the best article up here. Now, this is the Chinen article from Secondary Immune Deficiency. You must read this article. Jay, great article. It's Chinen and it's Jackie, 2010. This is right out of that article. So I summarized it for your fellows here. I think the next slide goes into it a little more. Oh, no, this is JAMA. I put Rodriguez in here because I found this one too. An earlier JAMA article that cytokines are increased through HIV. There's a lot of loading predicting the latency. Then without the drug, the CD4s progress and decrease down. I put this in because it's another study that talks about the specific HIV CD4 cells neutralizing antibody, overcoming the viral escape, and the patients then have fever, weight loss, diarrhea, fungal and viral infection. And then when the CD4 is less than 200, the patient presents with a lot of infection. Again, this is a JAMA article from 2006. Next slide. I think, again, this goes into the chemokines. Again, I put these pictures of the CCR4 down. So, and this is Baker's reference, an expert opinion. If the patient doesn't get treatment, repeated infection causes death. A small portion, though, remain asymptomatic and do not have AIDS, like Magic Johnson. These patients are called long-term non-progressors. You've heard about that. There's a lot of long-term non-progressors, fortunately, out there, and they're also being studied to understand the basis of their protection. So those who get levels of under 50 copies without treatment are called elite controllers. Baker, expert opinion, 2009. And the immunity is explained also by the CCR5 over here, receptor, a T cell molecule necessary for HIV entry. So right here, this was presented many years ago, but it's still important because here's the T cell and here's the monocyte. So the immunity is explained by the host factors, inherited defect in the gene for the CCR5. Okay, next slide. I just put that picture there to show you the monocyte.
So there actually are individuals who seem to be resistant to this disease.
Yes, there are some that are, not too many, and they're being studied at the NIH, and elsewhere, and it's interesting why they are. And I don't know. I don't do HIV clinic anymore. I see patients that are already treated by the IG docs. But yeah, it's very interesting that some people are fortunate that their immune system is assisting. And then we'll get into vaccine at the end. So the CCR5 have been found with significant prevalence in those of Northern European ancestry. Other factors of the long-term non-progressors are the low number of activated CD, that's not CD81, that should be CD positive T. Paul and Jackie, 2005. And then there were viral mutations along with this, and the diagnosis was made using an ELISA to look at the P24. Again, the HIV ELISA is done, and then the Western blot, and then the molecular work is done. Rapid diagnostic tests to rule out can use serum, saliva, or urine. So there's tests for the cheek now. They have tests now. You don't need an ELISA. You could do a test from the saliva. And there's specificity to the ELISA and can be performed in the office or at home. This is, you know, a lot of people are doing this, but again, you really need to go to a physician, and if this test comes out positive. And I'm not sure here if we use that or we still use the ELISA right now. I think we might do both. Next slide. Other useful tests are genotyping and phenotyping assays. The genotyping identifies mutations that confer resistance to drugs. So unfortunately, some people have resistance to medication, and that's a problem. So phenotyping measures the inhibitory action of the drugs on the isolated strain, which is similar to bacterial sensitivity. And they define the susceptibility profile. I did have a PhD in my lab many years ago, Jay, when you knew I had my program in my own lab, and I trained this doctor who now works at the Department of Health, and he worked on a lot of this work, and he's still there. So there's a lot of interest in all these tests. Next slide.
Is the resistance to these drugs specific to the strain of the HIV infection, or is it the host, something about the host that makes them more resistant to responding to the drugs?
Yeah, that's a good question. I think it's both, probably. Yeah, I think it's probably both. Yeah. Next slide. Yeah. Let's forget this. These are some of the drugs in clinical use. We're going to go more up to date. This is 2007. So we used to have all these drugs back then. There's a whole bunch of them here. The danicides. These are the generic names of them, and it used to be taking a lot of pills so many times a day. Then there is, but the reason I put it, there's a reverse transcription, and these are the nucleoside analogs. Then there's the reverse transcriptase inhibitors here, and then there's a protease inhibitor. So a lot of these drugs are being used in the HIV clinic now, especially some of these protease inhibitors, is the Adinavir, the Nalfanir. There's so many of them out there that the docs have to know what they do and what are the potential side effects. So it's not an easy thing if you are in HIV medicine today. But I put this here so you could see that these are a lot of different drugs and some side effects that can occur on these medications. But patients are living longer. Next slide. These are more, I think this is just to show it in a better format. Again, I remember using some of these myself when we were taking care of patients before. Again, it's just breaking it down again into the reverse transcriptase inhibitors and some of the drugs in clinical use. I remember a lot of patients were on the alfinazir or the Sustiva. It's one pill one time a day, so that's better than taking two times a day and then taking others in combination. Next slide. So again, same thing, but broken down so you could see it better. So we'll skip it because you can see they're all there. There's a lot of different drugs that are used. These are the protease inhibitors. Again, this one is 2 pills 3 times a day. And then this is 3 pills 3 times a day. So it's tough when you have to take so many medicines so many times a day. Or even this one. I remember ritonavir when we had our HIV fellowship, 6 pills 2 times a day. or 4. I mean, it's really tough for people to take all this, but now there's a lot of change. And then the fusion inhibitors can be used, which are sub-Q injection 2 times a day, and these are all the side effects. Next slide.
Why didn't they just put 6 times as much into one pill? Make it too big? Is that the problem?
I don't know. I mean, things have changed a lot. Like in sub-Saharan Africa now, they've developed it where they have the better drugs that you don't have to take so many pills. And we'll get into that toward the end because there's a lot of change here. And I don't go to all the HIV conferences anymore like I used to. I used to go to them every year to keep up to date because we see them in the clinic. And unfortunately, and even in my private office, you don't know because the patient is not going to tell you their risk factors unless you ask. So you have to ask their risk factors, and they may never have been tested. So, you know, you're going to see it eventually. We have it a lot in New York. Next slide. Okay, treatment. Now, this is from Kitahana, and I put this in because this is the effect of early versus deferred treatment for HIV on survival. And this is New England Journal, a panel on guidelines for adult and adolescent. So, in adults, specific therapy is recommended when the patient has the illness and is less than 50, or the viral load greater than 100,000 copies. So caution, though, should be exercised in other situations where viral resistance can occur, and there are adverse effects, as I said, including allergic and metabolic syndrome, because these people can get metabolic syndrome and allergic conditions, like a diabetic state. Next slide. They're not happy when they get metabolic syndrome. And a lot of references that I found to put in, you could PubMed it. This is a working group from 2009. In children, treatment is considered for any HIV infant because the disease progresses faster in older children. For those children older than 12 months, the criteria are similar to adults. And actually, I've invited Dr. Savita Pawa to my teaching day in October at this hospital. She runs the HIV Center at University of Miami. She's trained tremendously, worked with Robert Good. She was my co-program director for over 20 years and is now at the University of Miami. She has an article in Jackie last month, Savita Pawa. And I think I might have referenced her here, but she's a tremendous pediatric immunologist. So anti-HIV classes are defined according to their mechanism. They can be reverse transcriptase inhibitors, protease inhibitors, cell fusion. We talked about that, but in the last 2 years, the CR5 inhibitors have been added to the arsenal. So these are the references. This is the Maravac, this is 08, the Hicks review, and the clinical infectious disease, the references there. Next slide. Okay, more. Here she is, Dr. Pawa. Oh my gosh, Jackie. Oh, now, there she is, Jackie. Ooh, I don't know if that's 2000. This is an early article from her. Yes, so she has one last month. So Savita Pawa did a phase trial of intermittent subcutaneous IL-2 in pediatric patients. This is her earlier study in Jackie. Now she has one recently. Even Carlos Camargo, who you know, Jay, he was at the college. We did the vitamin D together. He actually, I'm sorry, it's not Carlos, it's a different Camargo. I'm sorry about that. He looked at responsiveness of T cells to IL-7 with higher cell counts. So these are some other studies from 07 and 09. So combination of 3 synergistic drugs from 2 different classes are known to be active for heart. Now, I saw a patient today who was on heart. In my clinic, I have Dr. Reno Patel here, my fellow, and actually I saw a lady who came on heart, and she's doing very well. Now, they've been effective in reducing viremia, restoring normal T cell counts, with drastic reduction of mortality. But they don't eradicate the HIV and need to be administered continuously. So if people stop taking it and think they're cured, they're not. So as an adjuvant to improve baseline immunity, the administration of IL-5 and IL-2 have been independently tested. And that was Dr. Pawa in 07. And that's when she was at Miami. And now she has the latest in 2012. And she'll be coming to New York if you want to hear her speak. She's great. You can invite her. She's a great speaker. Next slide. Bart Hayes was at the NIH with Tony Fauci. He was one of my attendings when I was at the NIH. Bart Hayes looked at critical issues in mucosal immunity for HIV vaccine. Jackie, 2008. Failure of the therapy to eliminate the virus emphasizes the need for preventive measures, and the research of the vaccine has yielded lessons. We're going to talk about that at the end about vaccine that Fauci talked about last year in Washington. The need to demonstrate specific cellular immunity and humoral response include mucosal protective immunity. And this is Bart's article in Jackie. Now, Lancet also talked about the first vaccine were based on strategies that worked to other infectious diseases, but there were problems with it, not providing significant protection, live attenuated. This is simian. The simian strains in the animal have been demonstrated to protect the monkey from simian immune deficiency, but safety were related to the recombination, the wild-type reverter strains. And so this was an interesting study by McGrath that said in Lancet, a novel approach using adenovirus vaccine HIV elicited a stronger response, but not in more than 300 subjects. This is the McGrath study, and there's more that's been done since that. Next slide. Okay, Lieberman. This is old, but I put it there. I put Lieberman here because he looked at the review of why antiviral lymphocytes fail to protect, and then the Bo-Asso-Shearer study, that chronic immune activation as a cause of immunopathogenesis. These are the references from these two, and the combination of both innate and adaptive immunity can fail. And you know Joe Belanti's book now, which is very good on innate and adaptive immunology, has a section on HIV. It's very important that the innate and adaptive response can fail to eliminate the infectious agent, and it persists, unfortunately, as chronic infection. With HIV, there's persistence for ineffective immune response, and then the virus can integrate into the host cellular genome. Hypervariability occurs and escapes recognition. And these are earlier studies, but kind of interesting, especially the one in Clinical Immunology, 2008. Next slide. Now, this one, Jay, you've seen this because you get the Annals of Allergy. You know Dr. Stokes, right?
Mm-hmm. Yes. Okay.
Your fellows have to read this because this, and I have two of my medical students here today with me and my fellow. This is Practical Implications for the Practicing Allergist Immunologist. It's a great paper. It's 2011 by Stokes in Annals. The articles were selected on matter of accuracy. And what was nice about this paper is it just went into some basics for those that don't see HIV. So some allergist immunologists, they just do allergy. They don't do immunology. You know I do immunology, and we have a lot of HIV in New York. So this is helpful for those that may change. They may leave your area and come to New York. So it's a good paper for practical implications. It causes immune alterations, and it leads to a deficiency. The dysfunction is caused by HIV and increases developing allergic and other immune. Now, I wrote a paper in one of the journals on allergic manifestations of HIV. They have a lot of IgE. They have Bactrim, hypersensitivity. They get urticaria, so they have a lot of allergies. So, you know, it's interesting they make so much IgE. So heart, which is what my patient was on today, is associated with reconstitution of function while offering protection for infection and can provoke other things. But patients with HIV can show a lot of prevalent allergic rhinitis. They can have, like the lady today had AR. They can have adverse drug reactions. Now, she came in because she said she thinks she's penicillin allergic, but she already knows she's Bactrim sensitive. So we have to do penicillin testing because she may need it, and then there's non-infectious pulmonary complications. This is a good article. I think the next slide goes into it a little bit more on the next slide. So in conclusion on this practical article, pathophysiology is associated with a unique diagnosis and therapeutic consideration while treating these patients. With the use of heart and the subsequent decrease in complications, they now live longer. And it's a chronic disease. It's like having diabetes. These people are doing well, fortunately, because of years of research from the NIH and other places that people that have medication and can afford it are living longer. But unfortunately, in Africa and other countries, not everybody gets the treatment. That's why Bill Clinton and the Yates Foundation is trying to help there with getting medicine to other parts of the world. Evaluation of HIV with rhinitis, asthma, and adverse drug may become more frequent as heart continues to extend the life. So you're going to see rhinitis and asthma and adverse drug reactions in HIV-infected people, and understanding the interaction with this virus can facilitate a knowledge to help to treat. And you know, HIV used to carry a horrible type of diagnosis, but a lot of people unfortunately got it from blood transfusions or got it from a partner they didn't know had it. So, you know, not everybody abuses drugs. And so we have to consider that these people are in our communities and we have to care for them. Next slide. Annals of Allergy. Routine immunization schedule. This is, I believe, the same one for the practical approach. So this is the routine immunization for those with HIV. For inactivated influenza, 1 dose. For pneumococcal polysaccharide, initial and a booster 5 years later. Hepatitis B, 3, tetanus. You still have to do these things because they could get pneumococcal pneumonia or they could develop other problems. Substitute 1-time dose of TAP, a boost with it every 10 years. For papillomavirus, that's another issue. When the clinician believes it can benefit, can be derived. And then for measles, mumps, rubella, and varicella, do not administer to immunocompromised. And then for hepatitis A, there's 2 doses. So this is the schedule in this journal for those that are infected with HIV. Next slide.
So MMR can be given to those when they're well controlled on the medications.
Yeah, because this is right from that article. Yeah, do not to severely immunocompromised. Yeah, because you don't want them to get measles or other things too. So.
Right, right.
So it's a good article. I think this is from the same article. Now this is, I put all the drugs here because the earlier slide for 2007 was hard to see. This is out of the practical approach. There's the nucleoside reverse inhibitors. Now there's a lot of them, so you don't need to memorize them all, but if you're treating these people, you need to know what they're on. They're on abacavir, didanosine, there's amitriptyline, the lamotavine, the tenofovir, and the Zyvote. Now this is the one I remember because when in the 80s, we used this drug, Zyvodine, we used that. Now there's the protease inhibitors, and these are the drugs. And I remember we used a lot of nalfinavir and ritonavir, but there's others. Okay, there's so many now. Then there's the nucleoside reverse transcriptase inhibitors, which are the enferazine, I try to pronounce some of them, the delaviridine and the nevirapine, and these are the fusion entry ones. This is the other one that's really, so this is nicely put on this slide, and I don't think it'll be on board to pick the drugs, but I know you wanted an update, so these are the antiviral drugs that are used now, and in the HIV clinic, they use several of these, either alone or in combination. Next slide. So go to the next one. I think it's still, okay. This is pretty recent in the Journal of Clinical Investigation. A little bit of basic science here for you, Jay. I know you like this. You like the lectin-6 and the FcRl4, right? You like that?
Absolutely.
Okay, Journal of Clinical Investigation. Now that's the journal from the AFCR where I'm going to DC with Dr. Patel in April. Dr. Fauci spoke last year at this meeting. It's a great meeting. It's every year in DC, cherry blossom time. Anyway, Cardava wrote this, attenuation of HIV-associated human B-cell exhaustion by siRNA downregulation of receptors. So I put it in because I thought it was interesting. Again, we already talked about immune activation. We talked about exhaustion and memory B-cells. The lymphocytes show expression of inhibitory receptors, which can contribute to the inefficiency of the antibody response. So in human B cells, we talked about that a lot, the siRNA knockout of 9 is known, and its receptors lead to enhanced proliferation of memory but not other subpopulations. And here's the interesting part. The strongest effects were with the inhibitory receptor called receptor 4, FCRL4, and the sialic acid binding, which is what we see in autoimmune disease for lupus, like lectin-6. It's called Siglec-6. That might be on the board. They may ask about the Siglec-6 as a receptor. I don't know. I'm not sure because I don't write board questions anymore. The extent of FCL4 knockout effects on the B-cell-mediated proliferation depends on this ligand with an inhibitory receptor engaging different pathways. And what's interesting about this is with HIV B-cell exhaustion, there's potential targets for reversing the deleterious effect of inhibitory receptors and persistence. So a nice article, very complex. Sorry about all this, but you know, I try to go very simple from the earlier slides, and now we're getting more complex on some molecular B-cell immunology. Next slide. It's a nice article. And this one is really nice. This one is Overbach. Actually, I brought all the articles with me, so I think I'm going to quiz my medical students here. They're looking at me, and they're looking and say, don't give us these articles, because they're in medical school. So Overbach, Cold Spring Harbor. Guess what? That's here in Long Island. You ever come to Cold Spring Harbor? Never. It's a great place.
There you go.
Harbor, oh, it's a beautiful place where they do all the gene work, and that's where the DNA guy, not Crick, I think one of them is still alive, and he's over there. Which one is it? Watson or Crick?
Watson? I think James Watson is still around.
Okay, then that's where James Watson is. He's at Cold Spring Harbor. Anyway, January 2012, the antibody response against HIV. Now, this is a tough slide. I like it because it's complex. You know I like complexities. I try to be simple. But this one is the mechanism of action of neutralizing NAB, N-A-B-S, NABs, and antibodies that act through the ADCC. You know what that is, antibody-dependent cellular cytotoxicity. You know about that, right? Effector T cell and the NK, right? Then what there is the NABs bind to the envelope and block the interaction of the particles with the CD4 and the the chemokine 4 on target cells. And then B, we're here, B is the ADCC, antibody-dependent cellular cytotoxicity, leads to killing of infected cells, and then there's a complex between IgG Fab bound to the envelope program. And then in C, we have the mediated virus inhibition, killing, reduction of virus production, virus inhibition by antiviral cytokines. There's granozymes of porphyrins. There's a lot of antiviral. I like this because it's very up-to-date. So I would make your fellows read this one because your fellows are all going to go into immunology, right, Jay?
Well, I guess so.
I'm looking at them, and some of them are saying, no, we like allergy. Immunology is tough. In fact, I'm seeing mast cell activation patients. You know what those are. That's another story. They're tough patients. Okay, so this is a great paper, January 2012. It goes into a lot of mechanisms of antibodies called NABs. Next slide. And this is nice. I put Kubi back in, and then I'm going to end with Fauci. Kubi is the Immunology Journal for Medical Students. Why I put it in, it was interesting. Why AIDS does not fit the paradigm for vaccines. Classic vaccines mimic natural immunity. Most vaccines protect, but not against HIV. Most protect for years that change very little over time, but HIV mutates, and there's a rapid rate of inefficiency. Most effective vaccines are whole, killed, or live attenuated. Killed HIV does not retain antigenicity. No, it's an old slide, but it has a lot of good stuff. Most vaccines protect that are infrequently encountered, but HIV is encountered daily at high risk. These people continue to be at high risk. They're medicated, but they still are risky. Most vaccines protect against infection through mucosal surfaces, and the great majority is through the genital tract and the GI tract. And they're tested for safety. Now, this is talking about vaccine. We're going to end on that. I think the next slide is more up to date. I put that in because, there he is. Who's that? Anthony Fauci, who trained me. Dr. Fauci Dr. Fauci was my attending at the NIH, and I took care of his patients. Back then in the 80s, it was not called HIV. It was called AIDS. And I had patients in the early 80s. We had no idea what was going on. We knew they were immune deficient. Okay, Dr. Fauci has this New England Journal of Medicine article, which you all have to read. I put his picture there because, you know, he's in D.C. and he gives a great talk, and he talked about the vaccine challenges and prospects. This is out of Margaret's article, who works with Tony. She's his PhD of many. He's got many PhDs. The selected obstacles to vaccine include the window of opportunity for the immune system to clear the infection is narrow, since the virus integrates and establishes latent infection. The destruction of the helper cells begins early, and there's enormous diversity and mutations that occur. And then there's conserved antibody targets, and they're hidden from the immune recognition. So these are the obstacles that Margaret and Tony talk about in New England Journal. This is an article, is a must-read article. Implications. Rational, empirical approach to vaccine have not been successful to date. The one in Thailand didn't work, but they're still working on it. So even back in 2011, they were not successful, but things are changing. Fundamental questions regarding disease and the host to the virus needs to be answered still. And there's new ideas. Maybe one of your fellows will become an HIV scientist and come to D.C. Think so? Maybe. You never know, because Margaret is very good, but there are doctors that are MD PhDs that want to study this. So there's fresh new ideas that are urgently needed. And we remain, again, this is out of Fauci, he remains cautiously optimistic that a substantial increase in our understanding of infection will lead to creative ideas how to design a vaccine. So I think that's the last slide with Dr. Fauci and the vaccine. I think so. I think, yes. So I hope that I wasn't too technical, or that I tried to be basic and then get into some understanding of HIV diagnosis and management. And I hope it was helpful, Jay. It was so nice that you let me do your COLA conference. And if you want, I could do mast cell activation a couple months from now.
So, yeah, that was very interesting. And obviously, the vaccine development has been a real hard nut to crack, because it hasn't responded the way normal viral vaccines work. And it's shown us that we don't really understand how long-term immunity to things like this work. There's a lot of mechanisms that remain to be understood.
Yes, absolutely.
So, comments or questions from the group? Anybody? Let's see. Brock, you have a question? Go ahead, Brock.
Yeah. Marianne is great, great hearing and great lecture, and I might add that she's a great dancer too.
Oh my gosh, who is this speaking?
This is Brock Williams.
Oh, Brock, what are you doing there, Brock?
Oh, I just kind of hang out, you know me. I have a question about the specificity of the protease from HIV. Is it a serine protease, or does anyone know about that? I'm sure they do.
Oh yes, they do, Brock. Because I forgot that you're still doing a lot of the SIGE and a lot of those immunoassays, right, Brock?
Oh, not so much anymore. I'm actually more into this component resolved diagnosis stuff.
Oh, I want to ask you about that. But you know what? As far as your question, it was a great question. I'm not a scientist that could answer that, but if you just PubMed that question, it'll come up, or you can ask one of the. I don't know.
My curiosity is about the side effects of the anti-protease, because we know that, and the relation to allergens. Many of our most potent allergens are protein, they affect protein-activated receptor 2.
Right.
And,
Absolutely.
And those side effects were really quite striking, and I'm just kind of wondering if that could be a link into why you see more allergic disease.
Oh, that's a great question. You know why? Because as you know, the proteases go through dust mite and mold. Now I have my allergy fellow, well, she's my asthma fellow, but we give immunotherapy and we do specific IgE in the clinic. So you're absolutely right, because we wrote some papers papers on dust mite protease, which goes through the barrier of the epithelial cells, and then the dust mite protease and mold contributes to allergy. So you're giving one of these protease, and so that's a great question. I think I'll check that one out. I like that question. You want to come and work in my lab? At Stony Brook, but not here.
I'm busy in Kansas dodging tornadoes.
Gosh, I asked Jay when I saw him in Orlando, did the tornado affect him? He said no. Were you okay?
Oh yeah, no problems.
Well, it's so nice. Why don't you come to D.C. in April and you'll hear more about this? But I don't know. You always ask great questions, and
yeah, Brock always gets the last word.
Yeah,
I was just wondering, is there any evidence for whether...
I remember you brought from Aspen Allergy.
Oh yeah.
Remember?
Yeah.
Well, you know what? I hurt my ankle in Brooklyn, so I can't dance as much, and I can't wear my high heels as much.
Yeah.
Now, Marianne, just wondering, does specific immunotherapy for allergens, is it effective in people with HIV?
Yes, good question. Absolutely. It's not a contraindication, and that's a good question because you're wondering if you're inhibiting some of these, antibodies and T cells, is it a problem? And there were studies that looked at immunotherapy in HIV-infected individuals, and there are people in New York City that continue to do it. It's not a risk, but to be honest with you, when I have a lupus patient and they're on immunotherapy, I'm a little cautious. So if they say their immunotherapy is helping their rhinitis and asthma, a lot of docs will continue to do it. So it probably does help, and there are articles on that. I just can't recall the authors.
Because I remember it used to be a contraindication.
No, it's not.
Okay, good.
But I think you have a great, I'm looking at your room there. You got 1, 2, how many fellows? 3?
We've got 3 fellows. We've had 5, but 2 of them had to go do a consult or something.
Oh, okay. So you've got 5, and I'm hoping they're all doing some good clinical, and are they doing any basic science studies?
You guys doing any basic science studies?
I'm a mix of that, yeah.
She's working in, Dr. Raji's working in the lab.
Oh, okay, great. Well, I will see them, I hope, in Anaheim.
Yeah, absolutely. Anyway, I'd like to thank you for this great presentation. It was illuminating as always, and we really appreciate it. At any rate, we're going to have to end here. It's noon our time, which is 1 o'clock your time. This has been Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics in Kansas City. Thank you for this presentation, and have a great week, everyone, and we'll see you next week.
Okay, thank you, Dave.
Bye-bye.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.